mic works too.
No, I said where they want to sit. Yeah, I hate people that tell me where to sit. I really do.
All right, it's 3 o'clock.
I think you all know me already, Pat Ramsey. I'm the chair-elect for the Texas Collaborative for Healthy Mothers and Babies. I'm also the director for outreach and maternal transport at our institution at University Health Systems in San Antonio and UT Health. And we have our simulation team here today, along with Moreno Hoffman, wherever she went, there she is, from Peterson Memorial Hospital up in Kerrville. And our simulation team today is going to take you on a deep dive through a different approach to simulation, which is kind of cool. And Dr. Gonzalez and Lolly will be talking you through that with our standard patient actor, Allison Moreno.
All right. Yeah, I'll take that. Okay, welcome. And thank you so much for having us here for this presentation. The title of our presentation is called Rapid Cycle Deliberate Practice for OB Emergencies, Implementing a Novel Simulation Strategy for Outreach Education. So one of the acronyms that we use, you know, we're kind of an acronym society today, right, is we call it RCDP. And it doesn't really roll off the tip of your tongue very well, kind of like TCHMB. The Texas Collaborative for Healthy Mothers and Babies, I think we all agree, is a wonderful conference. We're so thrilled to be here. It's packed full of all kinds of information. So I'm going to get started here. We've been doing RCDP for about 3 years now in the rural communities. We started out in 2018 doing shoulder dystocia. And last year we did postpartum hemorrhage. We kind of aligned with the AIM initiatives. And then this year we are starting out, this is our first presentation on eclampsia. So thank you for coming today. We couldn't do it without our team here. Dr. Ramsey, as y'all know, is our medical director for the perinatal neonatal outreach team. That's me, Dolores, or Lolly, Perry. And Allison Moreno is head of the transport team at University Hospital, and she's our standard patient actor. Nick Guevara is our data analyst. He does all the data for us. You know, they say on the dollar bill, in God we trust, all others data, right? And Dr. Gonzalez, our guru, our sim guru, our mentor, and he has really been fervent about rapid cycle deliberate practice, and I think you'll see why here this afternoon. Last but not least is Rebecca Terrazas, the director of our perinatal program, a woman who has just made sure that we're able to do all this. We want to thank her because none of this would be possible without her direction. Okay. Okay. Oh, I almost forgot our actors. Please, no. So we have Moreno Hoffman. She'll stand up. From Kerrville. She's from Peterson Regional Medical Center, PRMC. And then our university girls, Miss Marisol Breton Leja and Caitlin Maddox. Before we do our actual sim, Dr. Gonzalez is going to give you what it's all about, what rapid cycle is all about. Thank you, Dr. Gonzalez.
Thank you. Yeah, can you hear me? Yes, they can hear me too. Thank you. So first of all, thank you for the invitation. Thank you very much. This is a lot of fun, a lot of work, and that's what we enjoy doing. How many do simulation in their institution? Okay, so it seems like, gosh, 60, 70%, I guess. How many do rapid cycle deliberate practice? One? Oh, so we have someone that does RCDP. Yay! So we're going to talk about this kind of novel, new methodology of doing simulation. Totally different than standard sim. So just kind of follow me. We're just going to develop the theory, a little bit of the theory behind rapid cycle, and then we're going to actually talk about what we actually do. And we also, I believe, gave you a toolkit. I think there's a handout at your tables about the rapid cycle toolkit. So if we have time, maybe we can go over that a little bit. So I have nothing to disclose. The standard joke up here is I wish I did, but I don't. And the objectives basically is the first part of the lecture is to review deliberate practice, which is the theory behind RCDP by K. Anders Ericsson, and then actually review the rapid cycle deliberate practice by its originator, Betsy Hunt from Johns Hopkins. So think about an effective team that you've seen in your past. Think about it. What made it, in your definition, an effective team? What made it into such a good team? Did they have a plan of action enunciated by the entire team or by the leader to the entire team? Did they have a defined duty for each individual, right? Did they have good choreography? Did they have good ergonomics, right? And did every team member, were they truly highly valued, right? I mean, those are all really cool things about a good team, right? Right? And I know you've seen this stuff before, but kind of look at it. It's about 1 minute and 40 seconds about what a really, really good team looks like.
Pit stops have been a part of motor racing since the very early days. What's important is to know that you can bring the car in and you can service it reliably every single time. And we're being able to do 2-second pit stops. In any one pit stop, we generally have 18 people who are touching the car. The great thing about a Formula 1 pit stop is it's about getting these 18, 20 people to have a good day every day and all at the same time. We spent an awful lot of time putting people into roles where we thought that their body fit was comfortable, but also they were comfortable. The first thing that happens when the car comes into the pit box is for the front jack and the rear jacks to lift the car up. Pretty much the second the car's in the air, the wheels are coming off. And then the magic really is in how these guys take the wheel off, put the wheel on without banging into each other. And we spend a lot of time looking at the choreography of a pit stop. We really work as a team. Every single person makes a massive contribution.
So was that a great team? It's kind of like our OB teams, right? And our neonatal resuscitation teams, right? Just like that. How did they get that? How did this group of people get to be such an amazing team? How did they do that, right? How did they do that? Well, let's ask Michael Jordan. What? Michael Jordan, a Hall of Fame American basketball player. What does he say? He says, some people want it to happen, some people wish it would happen, and then there's some people that make it happen, right? So how do they make it happen? We want to be in that make it happen thing, right? We don't want to be wanting it or wishing it. We want to make it happen, right? So how does it happen? Well, let's ask this guy. His name is K. Anders Ericsson. I think he's Scandinavian or something, right? And so he's a psychologist, I think in Florida somewhere, actually, but he is Scandinavian. But he is one of the world's experts on how to be an expert. Got it? Okay, so let's ask him. Let's ask him as to how to become this kind of person that makes it happen.
We kind of distinguish between naive practice and deliberate practice. Naive practice is people who just play games, whether it's basketball, soccer, or somebody goes out playing a golf game. So they're just accumulating more experience. We differentiate that from when you actually pinpoint something you want to change. And once you have that specific goal of changing it, You will now engage in a practice activity that has the purpose of changing that. How do you actually apply these ideas of deliberate practice?
So, aside from having goals, what else is he saying to us about deliberate practice? It's about repetition, 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 practice, practice, practice. And along with that goal-oriented practice, you've got to have feedback, immediate, directed feedback. And he also states, don't work on your strengths. You've got to work on your weaknesses, right? And then the last thing is you've got to work on the little things. Break it apart. Break the scenario totally apart into multiple segments and make it manageable for the team. So that's the theory really behind deliberate practice, what Kay Anders Erickson, an expert on becoming an expert, talks about. Okay? Does that make sense? Does that make sense, folks? All right. So let's go back to our great American philosopher, Michael Jordan. All right? What does he also say about deliberate practice? He says, I've missed more than 9,000 shots in my career. I've lost almost 300 games. 26 times I've been trusted to take the game-winning shot, and I've missed. I've failed over and over and over again in my life, and that is why I succeed. What? What? When I'm going like, what is he talking about when I first read that, honestly? And so, as opposed to dishonestly. But the deal is, there's a gift in failure. We don't like to talk about this in our society, right? We do not like to talk about this. But there's a gift in failure, and it gives us the opportunity to get in touch with our humanity, with who we are, right? And that's humility. That's really humility. When I touch my humanity, I'm actually doing humility in my life. And also, he says that this is giving us a gift of self-awareness in terms of our unique limitations of who we are. And then, hopefully, this will give us the gift of wanting to be eager for self-correction, for correction and improvement. That's the meaning behind his, I failed and failed and failed, and that's why I succeed, because it's given him this gift of self-awareness of his unique limitations. Does that make sense? Does that make sense? We don't talk about that very much. We just honestly don't. But it's something that psychologists are talking about, actually. And so we have to remember what our mom and dad said to us when we were trying to learn how to play the piano. Practice makes perfect. Practice makes perfect. Well, Kay Anders Erickson actually says that practice makes permanent. Not necessarily perfect and not necessarily better, but permanent. And he says that actually deliberate practice, this phenomenon that he's studying, is actually the thing that can cause improvement. All right? All right? So that's kind of the theory behind deliberate practice. Does that make sense? Any questions about that? Any questions about deliberate practice as in terms of what Kay Anders Erickson, how he defines it? All right? So let's go forward to talking a little bit about rapid cycle deliberate practice, because that's what we're doing today here, all right? We're doing rapid cycle deliberate practice. And for that, we have to talk about Betsy Hunt. Betsy Hunt is a pediatric intensivist up in Hopkins. As you can see by all her credentials, she's a big shot. She's a real big shot at Hopkins. And so what was going on with Betsy? So she's running a sim lab at Hopkins back in 2007, 2008, 2009. And so she's doing all these wonderful simulation drills to get her residents up to snuff in terms of doing resuscitations of patients that have pulseless arrhythmia. All right? You have a pulseless arrhythmia, therefore you don't have any cardiac output, right? You don't have any cardiac output. So AHA, American Heart Association, says that when you have a pulseless arrhythmia, like a PEA, pulseless electrical activity, or pulseless ventricular tachycardia, or something like that, that the first thing you need to do is what? Pump on their chest. And it doesn't mean that if you call out for help or you ask someone to get the cart in, that you're an evil person. It just means that the patient that you're working on may not be revived, all right? And so the AHA says you need to do this within 1 minute after the initiation of pulselessness. That's the deal, all right? That's the deal. So she was doing all this stuff, you know, PALS education, she was doing AHA education, she was doing standard sim education, and what did she find? What did she find with her residents back in 2007, 2008, and 2009? In fact, she published it in Resuscitation. The delays and errors in cardiopulmonary resuscitation and defibrillation by pediatric residents during simulated cardiopulmonary arrest, Hunt et al., Resuscitation 2009. What was her conclusion for this pulseless arrhythmia? She found experience and previous training made no difference. 66%, 2/3 of the residents that were being trained didn't start pumping on the chest in less than 1 minute. 1/3 of the residents never, ever pumped on the chest during the entire drill. 54%, there were only 54%, about half of the residents initiated defibrillation in less than 2 to 3 minutes, and they're supposed to. All right, so it was awful. It was awful. It was very disheartening for Betsy Hunt. Very disheartening. She says, "Oh my gosh, what's happening? What am I doing? You know, I'm wasting my time." And she also found that there was no difference between first-year residents and third-year residents. So education and experience didn't matter, you know? So my goodness, so she says there's got to be something different that we can be doing to help these people. And so she said, she said, if the goal is achieving competency and mastery in a short period of time, efficiency matters. And so giving participants the answers is more efficient than letting them figure it out. Teaching the right answer is more efficient than facilitating a discussion. Knowing full well that this kind of method will not improve their critical thinking skills. All right, we know that. We know that. All right, it's not going to improve your critical thinking skills by doing what we're going to be doing today, but it will do something else. It will give your muscle memory a little bit of a clue about what you need to be doing next. How to do it, okay? What to do and how to do it. All right. So that's what Betsy said, and she also said or thought that you just cannot teach them what to do. You have to teach them how to do it by repetition with focus and a coach, pattern recognition, scripts, choreography, memory prompts, cognitive aids, whatever. Give it to them. You're going to be totally transparent. You're going to let them know exactly what you expect of them. You can write it on the walls. You can write it on the walls, you know, during the drill so that they'll remember. That's okay. It's totally different than standard sim, isn't it? I mean, I'd been doing standard sim for about 10 or 11 years when I got exposed to this. I'm going, oh my God, I don't want to do this. This is like heresy. It's heresy. You never do this in real simulation. All right? But I've been converted. All right? So there's nothing worse than a recently converted person, right? And also, what else really helps with this is there a definite best practice available, like established guidelines, ACLS, ATLS, shock guidelines, ASA, difficult airway algorithm, ACOG, procedural elements of shoulder dystocia, NRP, depressed newborn at birth, right? The answer involves the right way to do it. It's incredibly helpful, incredibly helpful. Like I said, I've done standard sim. I've done it for a long time, you know, and I could probably write objectives in a scenario in my sleep, right? I've gotten pretty good at it. This takes a long time. This takes a long time to put together because you really have to get it right. And you have to get, you have to get all the people on your faculty and your coaches to agree. This is how we're going to do it. This is how we're going to do it. All right? So let's compare and contrast Erickson's deliberate practice to Hunt's rapid cycle deliberate practice. So with Erickson, you have goal setting, repetition, feedback, weaknesses, work on weaknesses, and focus on the little things, break it down into manageable parts. And now Hunt has allowed this to go forward, and she says, you know what? We need to do certain objectives, but we don't necessarily call them objectives, we call them pause points. And what does that mean? That we're basically breaking down the scenario into maybe 4 or 5 different subsegments. And these pause points are the objectives for each segment. And if the team doesn't achieve 100% of these pause points, you don't move forward. You don't move forward. You stop, you pause. We used to say stop, but now it's not. No one wants to say stop because it's traumatic. And so now we say, so now that's okay. That's okay. I'm there. We don't want to be traumatic. So we pause. Now we pause. Okay, we don't say stop. So we pause and we say, okay, this is what we did right or what we did wrong. Let's rewind, start all over again. So we start all over from the very beginning and then one more time do it. Okay, and then we hopefully pass that point to the second pause point, and then like today we have 5 pause points, right? So we're gonna have 5 little subsegment drills within the big drill. Okay, does that make sense? So those are the pause points. We have also the participants in standard sim are blinded, right? They're totally blinded. You don't give them a clue as to what this is all about. In RCDP, you tell them all about it. That's what we're going to be doing today to our participants as well, all right? We tell them all about it. We give them as many hints and things as possible. It's kind of like a Broadway play. It's kind of like a Broadway play. You know, you do the rehearsals for finally the big event, right? Opening night. And so that's hopefully the last cycle of the drill. Okay. Oh, I didn't finish, did I? Forgive me. So then we do multiple cycles, rapidly cycle between deliberate practice and directed feedback, and we do micro debriefings. For us standard sim folks, this is very difficult to keep a debriefing to like 1 or 2 minutes. And we typically want to do like, oh, well, what did we do right? Well, what do you think how could we have done differently? And what are you taking home today? No. You say, okay, you did this wrong. This is how we're going to do it. Let's rewind, start all over again. Got it? Okay. All right, so that's the deal. Totally different. Okay, so what does Betsy Hunt say are the 3 main principles for rapid cycle deliberate practice? Number 1 is give them lots of time in deliberate practice. That's what she says. Don't spend a lot of time doing other things. We got to drill them. We got to do it. Give them the time to practice, okay? And these are all based on the education theories of overlearning, automatization, and creating muscle memory. Second is expert feedback. You're going to give them and tell them exactly what NRP says about resuscitating a depressed baby. This is the way we do it. This is the way it's said that it's done, and so we're going to do it this way. We stick to it, right? Give them real-time feedback and directed feedback. And we have to create psychological safety. This is really very important. We have to get the student, the participant, to acknowledge the fact that we're their coaches and we're here to coach them. We're not here to do ugly things to them, that we're here to coach them and to make them better people. Just like world-class athletes accept coaches, just like musicians accept coaches, right? And so that's the major thing in terms of our introduction that we really do need to stress and get them to accept. And a lot of times, what we do is we do the first cycle all the way through and with all of the mistakes with them, and then we go over that very quickly, and then they get it. They go, oh yeah, we didn't do that well, did we? So that's typically what Betsy Hunt recommends, is for the first cycle to not follow the RCDP rules, but to just let it go all the way through, and that's kind of your baseline. Does that make sense? All right, so create an environment where participants understand the goal is coaching them, no defensiveness, don't fear making mistakes, welcome the coaching, appreciate practice time. All right, so one more time, compare and contrast standard sim versus RCDP, objectives versus key pause points. blinded participants versus non-blinded, single uninterrupted drill, micro debriefings, debrief and reflection versus rapidly cycling between deliberate practice and directed feedback. All right? All right, so how about, okay, so when does standard sim come in? When do we want to do standard sim versus RCDP? I still believe in standard sim. I love standard sim. I love debriefing. I think that's the heart and soul of simulation is debriefing, right? When you ask the participant to do some self-reflection in the face of objective truth, which is the video, and accept their behavior. That's gold, isn't it? That's absolute gold. I still believe in that. But there's a place for that, and I think there's also a place for RCDP as well. Betsy says the following. You can tell I'm a big fan of Betsy Hunt. She's incredibly awesome. So if time is of the essence, failure is equal to life-threatening situations, and you cannot afford to let people fail and must ensure competency efficiently, you tend to maybe want to go to RCDP, okay, versus standard sim, okay? All right? All right. So Betsy redid her evaluation of residents, but this was in 2014, and she did it via the RCDP first 5-minute methodology. And what happened? All of the residents pumped on the chest in less than 1 minute, and all of them started doing defibrillation in less than 2 minutes. So that was really pretty amazing, you know, for her. And she said, you know, this, I think, is helpful. She's not saying it's the end-all of simulation, because there's a place for it, and there's also a place for not doing it, right? Okay? All right, so just as a summary, rapid cycle delivered practice, coined by Betsy Hunt in 2014, novel simulation strategy, uses short cycles of pause, debrief, rewind, and try again. Do it right, gives the participants lots of opportunities to do it right. Coaching is incredibly important. And it's really good for the first 5 minutes of whatever, right? Of whatever, resusces, you know, whatever you want. And it's also incredibly helpful if there's an associated algorithm, right? Put out by an agency that looks at those kind of things, all right? And the goal is taking the participant from uncertainty to mastery. So let's hear from Betsy Hunt. See, what does she have to say about RCDP?
We're going to do a simulation. We're going to break it into pieces where we're going to do 2 or 3 minutes of a sim, and then we're going to time out. It could be because you did something fabulous. It could be something that you did wrong. It could be something I'm just curious about. We would give them very direct feedback. There's this thing that I just noticed. I need you to do it a different way. And now I'm going to tell you how to do it, or I might even show you how to do it. It is important to get the learner into that frame of mind of being able to make mistakes. Then we learn from our mistakes, we try again, we figure out a new way, we do it right several times, and then that becomes our new pattern.
Rapid cycle delivered practice provided me with a way to focus training.
How to look at patient vital signs, look at patient condition, patient labs, ask questions and make mistakes. Focus on the key interventions.
Things that are sort of really high risk and low frequency, where we don't get to see a lot of it clinically.
Specific objectives, measurable objectives. Do each one of the different roles and responsibilities. Look at what we've done so far, what we can improve upon at that moment.
If we do something poorly, we want opportunities to fix it.
The rapid cycle delivered practice provided us with a way to help people remember what they needed to do.
We're like coaching them, we're teaching them, and we basically changed the teaching style completely, and it changed everything. So now when we measured them at the end of the year, they were quite a bit better. That's what I love about RCDP. This curriculum was making a big difference.
Okay, thank you very much. Do you have any questions at all about the methodology of practice? Okay, thank you very much. I have a question. Is there online resources to what you're telling us? Is there an online resource to this? Hopkins is an incredible, and Texas Children's as well. I mean, they've been doing it the longest. Is Johns Hopkins, of course, because of Betsy Hunt, and Texas Children's as well. The majority majority of the RCDP literature has to do with pediatrics, because Betsy is a pediatric intensivist, and so that's where it started. That's where it started. But we're you know, we say, you know, we can do this with adults. So it's starting to come about with adult medicine. But there's not a lot of adult medicine literature. We've put some together. We reported on our shoulder dystocia experience, and we presented that, and we're hoping to publish that. But it really is, it's incredible the response by the participants. Like I said, I've been doing SIM for about 12 years or so, and the response from the participants about their RCDP experience is just amazing. You go, oh my gosh, this is what I've always wanted to do. I always wanted to repeat it and see if I could do it right. And at the end, teams that we thought at the beginning, oh my God, they're never going to get an RP. They're never going to get an RP. Seriously, at the end, after a couple of hours, at the end, they're doing world-class NRP. And you go, oh my God, I never thought they were going to get it. And the participants, they've been in tears, going like, oh my God, this is so wonderful. I really never thought I could do this, you know? Now, the thing is, the literature still doesn't have long-term follow-up, just because it's not that, it's relatively new. So to be perfectly honest, as opposed to dishonest, we still don't have that long-term follow-up data that we need, okay? We definitely do need that data.
Question over there.
Oh, it's okay.
So when you are implementing this new model, how much time do you set aside
That's an
for
excellent.
sim day or sim afternoon or whatever it is that you
It's very laborious and very time consuming. It is. What we do, Lolly, Lolly and Allison, do you want to kind of go over that in terms of our outreach? What we dedicate to?
Well, just briefly, we do the sessions in 4-hour slots. So sometimes we'll do
Yes,
two-day
sir.
workshops. And we'll do 4 or 5 participants. And so we usually do the rural hospitals that don't have, you know, as many nurses as larger facilities. But it's helpful for them for very low frequency type things like we're going to do here today. But yeah,
so it's blocks of 4 hours.
Yeah, we do 3-hour blocks typically.
4-hour blocks with a group of 4 to 5 people.
We do a 1-hour didactics. We dedicate 1 hour didactics, and we put aside 2 hours for drilling. And sometimes we absolutely need those 2 hours, and maybe more. And then sometimes it's really incredibly surprising. They get it after 2 or 3 cycles, and you're going, whoa, that's awesome. You know, it's kind of depends.
And this is for larger scale postpartum hemorrhages and things of that nature. So these are involved processes that you can put into a 4-hour session with them both. Thank you so much.
Thank you. Thank you.
I know y'all dying to see our sim. We're dying to do it too.
So let me just go ahead and introduce that sim a little bit. My name is Nicholas Guevara, as you may have heard. I'm the operations manager for the perinatal neonatal outreach program, and I do a little bit of the statistics and data analysis for them. So we are about to begin the simulation section of our presentation, in which we will demonstrate a condensed version of our outreach training program that we do. So this will include a brief lecture on the definition, management, and possible complications of hypertension in pregnancy presented by Lolly. Then we'll cover the script of the simulation and the expectations we have as coaches, including pause points, appropriate simulation behavior, and typical simulation etiquette, as covered by Dr. Gonzalez. And then to conclude the series of lectures, we will have an introduction to the standardized patient actor, Allison Moreno over here. And then finally, we will begin the rapid cycle deliberate practice drills. So, everything you're about to witness from this point on is a simulation of a simulation. Yeah, it's a little matrixy. as you'll see right now, the presentations have been heavily shortened, and all of the participants have been instructed to act out everything, including mistakes. And the parting words here are, although the credentials of everyone involved here are real, their actions are not. So, and I'll hand it off to Lolly to start talking about hypertension to our participants.
Okay, so this is the beginning of our simulation of simulation. Guys, so y'all want to gather around over here? Let's see where we can go. Okie doke. Can y'all hear me okay? Do I need the microphone?
Yeah.
Yeah.
Yes, please.
I just don't know how to turn it on. Ah, the on button always helps. Okay, go ahead.
Question.
Uh,
I'm sorry. It depends on the actors.
Pardon me?
You have to use the microphone so they're going to record.
Oh, okay.
I'm okay with it.
All right.
We'll have to hand the microphone around.
Just remember this side is my best. All right, so we begin with a little didactic. So I'm going to try to make it as short as we can so we can get into the sim. So guys, I want to thank you so much for coming here today. We are going to do a simulation concerning eclampsia today. Have any of y'all experienced an eclamptic seizure or taken care of a patient with eclamptic seizure? No. So it's a very rare, it's what we call low frequency, high risk complication of pregnancy. Although y'all probably take care of preeclamptic patients on a daily basis, right? Okay, so my name's Lolly, and this is Marina? Yes. Marina, Katie, Allison, and Marisol, correct? Okay, so even though this is a simulation of a simulation, I have to tell you that I have no disclosures, any financial disclosures. And I know this doesn't look like it's about hypertension, but it's impossible to talk about severe complications in pregnancy without noting that the maternal mortality rate in the United States is increasing, and pretty substantially. You can see by the graph, the black line, in the United States, maternal rates are increasing, whereas in other countries, they're decreasing. So what's going on? What's going on in our great state of Texas? Well, we have the same problem here in Texas. Oh, thank you, Vanna. And so Texas is where we live, play, eat, pray, love, and have babies. Oh, I'm not supposed to look at y'all. Okay, so we see that these are the usual suspects, the players for maternal mortality and morbidity. Even though hypertension and eclampsia is not the first, there's a bunch of overlap on all the other complications of pregnancy that lead to morbidity, severe morbidity. So, next slide. Yeah, so preeclampsia with severe features. That's a pretty busy slide. And I know y'all are all well versed on what preeclampsia is. And just to make sure that we're on the same page. When we report to providers, it's very important that we're all speaking the same language. So we know the classes of hypertension. We have chronic, which is what type of hypertension?
Hypertension prior to 20 weeks.
Okay. And then we have gestational hypertension, which is after 20 weeks. And then there's the preeclampsia that also there's, different forms of preeclampsia. Severe forms are eclampsia, and that's what we're going to do our simulation today, and HELP syndrome. But we're going to focus on eclampsia. So with severe preeclampsia, or preeclampsia with severe features, I want you to be really aware of, because this is going to be really important in the drill, those blood pressure values that are triggers. They're hallmarks of the whistleblowing, saying, you know, I need to call the doctor, and I need to call the doctor and make sure that provider is here at the bedside to evaluate and see the patient. And all that depends on my assessment, my accurate assessment and communication. Because it's well known that any kind of delay in diagnosis, any kind of delay of treatment is responsible, over half of these complications are preventable. Okay, so let's go ahead. Next. So eclampsia, I think you know, is a woman has tonic-clonic seizures and in the absence of any other signs of dysfunction or neurological things. And this is typically in a woman with hypertensive disorders of pregnancy. So what's the clinical presentation? Well, kind of looking back at all and gathering statistics about eclamptic seizures, it's overwhelming. Hypertension, that's no surprise. That severe hypertension, a woman who has an eclamptic seizure, over 3/4 of all women have hypertension, and about 2/3 have that headache. And that's part of your assessment. When we're doing our drill, and in real life, right, we do an accurate assessment. And it's not just asking the question, do you have a headache or whatever, but we need to make sure our assessments are accurate, and other questions that we're asking about visual disturbance and epigastric pain, palpating for any abdominal pain, right upper quadrant pain, that we know that are the hallmarks of severe preeclampsia, okay? So, severe hypertension, again, those blood pressures, the 160 over 110, those are the blood pressures that are very important for us to realize. Again, they're the sounding board. They're like, I'm calling the doctor and I'm calling the provider, and I need to see that provider here at the bedside, because we don't want to delay treatment. We just said we don't want to delay treatment. We don't want to delay therapy. Our first line treatments are IV labetalol, hydralazine, and nifedipine. So here's a protocol that ACOG so nicely has put out guidelines for emergent therapy for acute onset of severe hypertension. So do y'all have protocols for severe hypertension? Okay, super. That's great. And which medication should the doctor start with? Okay, so physician preference. But we do know that any of these protocols, algorithms, need to be started immediately with that severe hypertension, with those blood pressures that we spoke of. And magnesium sulfate. You also want to initiate that to make sure the blood pressure stays low, right? No. Trick question. Couldn't fool y'all, right? So we know that magnesium is what for?
Prevents seizures.
Okay, so we want to target our treatment at lowering blood pressures and prevention of seizures. So, next slide. So this is kind of surprising that we talk about delay in diagnosis, delay in treatment, and I was surprised to find by one of the AIM modules that monitoring blood pressure is one of the most inaccurately performed assessments. So assessment, assessment, assessment. We as nurses are the eyes and the ears for the provider. We're guardians of our patient's care, so we have to be accurate in assessments and in communicating. Okay, so the checklist, ACOG's checklist, is quite a busy checklist. So we just want to emphasize the points that are important for us during this simulation. Is a good assessment and calling out for help when we need to reassess that if we have that emergent blood pressure, which is what?
So 160 over 110.
Okay, so when we get that, we're gonna call out for more help, get IV access so we don't delay the treatment, and give an accurate report to the physician. In the case that the patient begins a seizure, we have to make sure that we are protecting that patient. We're the guardians of care for that patient. And then we need, without delay, start medication administration in the form of magnesium sulfate to prevent seizures and labetalol to lower the blood pressure. Finally, documentation is important. We all know that as nurses, but besides being medico-legally important, we have to know the timeline. We have to know when we called the doctor, when the doctor got there, and formulate some kind of delivery plan for the patient, patient-friendly language. We need to involve the patients in our care, and with that debriefing. So, finally, blood pressure, systolic 160 over 110. You know those values like the back of your hand, right? And when you get those values, it warrants a prompt evaluation of your provider at the bedside in order to treat the condition, decrease maternal morbidity. And this last sentence came straight out of ACOG's bulletin that recently came out that's telling us that risk reduction and successful clinical outcomes for eclampsia require avoidance of severe systolic and diastolic hypertension and management of hypertension in women with preeclampsia. So that's what we're doing here today. Next slide. Is just simulating, because there's plenty of evidence out there that tells us that simulation and standardization of care improves patient outcomes. You have any questions about that? Okay.
Thank you. Well, thank you. So we're going to now talk a little bit about our objectives of the drill. Thanks again for participating in our drill. So again, just to introduce you to this new methodology of doing rapid cycle delivered practice. It was coined back in 2014 by a lady by the name of Betsy Hunt. She's a physician at Johns Hopkins Hospital. And it's novel. It's a novel simulation strategy. And it has all these multiple cycles, short cycles of pausing when the mistake is done, and then doing a quick micro debriefing, very, very quick debriefing, not prolonged, and then rewinding, and then starting all over again. So if we don't pass through the pause points, or if we don't do well with that particular segment of the drill, we're going to stop it, we're going to pause it, and then we're going to talk about it for just a minute or two, then we're going to rewind and start all over again. Okay, that's what we're doing today. Totally different than what you've done before, I'm sure, in your simulation studies. And it gives you a really good opportunity to do it right at the end. You're going to be doing it right. And coaching is key. We're going to be your coaches. Lolly and actually Allison as well. We're going to be your coaches. When things don't go quite as well as we want them to be, we're going to pause you, we're going to talk about it, and then we're going to give you direction as to how to do it correctly. All right? This methodology is particularly good for the first 5 minutes of things, like codes and resuscitations. And the goal here is to take you from uncertainty to mastery in a relatively short period of time. Okay, any questions about the methodology that we're going to be using? No? Okay. So this is actually the eclampsia checklist that Lolly was talking to you about just a few minutes ago, and it's very complicated. And the team, she did a lot of work with this, and she broke it down and simplified it. And she talked about that just a few minutes ago. And what we're going to do, we've created now a scenario, a drill that encompasses all of these things. All right, and it's going to be broken up into 5 drills, sub-drills, all right? So let's go over the script. So Allison Moreno, who's our standardized patient actor, she's actually going to be Allie Monroe. That's who she is. She's a 31-year-old, and we're telling you exactly what's going on with the drill, all right? We're not holding back anything. Any questions that you may have, in terms of what's going to be happening, please ask. Please ask, and we'll tell you. We'll tell you. So Allie is a 31-year-old gravida 1 para 0 at 38 weeks gestation, comes to the OB triage complaining of severe headache. Allie is in a gown, sitting on a bed, no monitors attached, holding head in noticeable pain, and she has tea-colored urine at the bedside. All right? So this is our first pause point, and that has to do with patient assessment. RN number 1, and Lolly, have you determined who RN number 1 is going to be?
Okay, so Katie is going to be our RN number 1. She's
Okay.
the primary nurse.
All right.
And then, Marina, will you be RN 2? You'll come in when she calls out for help.
Okay.
And Marisol, you're going to be our scribe, and you're the third person that comes in.
Okay. So RN number 1 is going to interact with the OB triage patient. You're going to elicit a patient history. And then from that patient history, you're going to do a focused exam. Vital signs are obtained, electronic blood pressure initially, and then you're also going to do some form of neurostatus as well. So what is the history for this patient? You have Allison, what kind of history are you going to be giving the participants?
I have a severe headache. I've had a headache since last night. Nothing's making it better, and it's 8 out of 10.
And you also are going to inquire about the fetus. So what's the situation with the fetus?
Normal fetal movement, no loss of fluid, no bleeding, no other complaints.
Okay. And then vital signs are unremarkable except for the fact that we have electronic blood pressure of 188 over 118. And she has 4+ hyperreflexia. And also you have 3-beat clonus, all right? So that takes you to pause point number 2, which is the scenario where you have to call for help. You have to call for help. So RN number 1 is going to call RN number 2 to please come in and to bring in the manual blood pressure. You need to have corroboration by manual blood pressure. Is that correct? Gold standard, is that right? I am not an obstetrician, I'm a neonatologist, so I depend on my content experts to tell me these things, and that is correct. That's correct. All right, so we need to have the gold standard of a manual blood pressure. And then RN number 2, you're going to be establishing a peripheral IV, and you're going to initiate fetal monitoring as well. RN number 1 is now needing to call the doctor after the manual blood pressure is obtained, and you're going to give the doctor what? You need to give the doctor a very concise history of the patient with vital signs. Have patient neurological status as well as fetal status. And what is it that you want from the doctor? You're giving, this is what the doctor needs, but what do you need from the doctor in this kind of situation? You need to have meds and you need to have labs, right? So you give the doctor this following history. 31-year-old gravida 1 para 0 at 38 weeks gestation, complains of headaches, blurred vision, epigastric pain. Vital signs are normal except for the manual blood pressure of 220 over 110. And she has 4+ hyperreflexia, and she has 3-beat clonus, fetal heart tones in the 150s with minimal variability. That's what you're going to tell the doctor, okay? And so you also need from the doctor what Lolly went over a few minutes ago in terms of meds. We've already talked about this. And also anti-seizure prophylaxis, which is magnesium sulfate. Lolly, is that correct?
That's correct.
All right. And we need labs as well. We need a CBC, we need electrolytes, we need BUN, we need creatinine, we need a urine protein, we need an LDH, we need some liver function tests. All right? So then we go to the third segment of our drill, and that is recognition and initial management of a seizure in the patient. So the patient experiences a 30-second generalized tonic-clonic seizure. Fetal heart tones go down into the 60s. So RN number 1, you announce to the room, even though it's obvious, some people may not be looking at the patient, some people may have something else going on in their minds, wanting to do a good job. We want the leader to announce to the room, the patient is having a seizure. RN, and then also RN number 1, we want you to call for more help in the form of RN number 3 to get her to help you, to be the scribe, and also to go ahead and call the doctor and let them know that now this patient has a seizure situation going on. And we want to protect the airway and improve oxygenation in the patient, which means what? Putting the patient in lateral position, providing supplemental oxygen, and making sure that there's a pulse oximeter monitoring the patient's SATs. And then the second part to this segment is the RN number 1 asks RN number 2 to make sure that those bed rails are up as per the ACOG patient safety checklist, and to check on resuscitation equipment, bag and mask, as well as suction, and to continue the fetal surveillance. Any questions about this? Any questions about these segments that we're going to be pausing in case things are not going well? Any questions at all? Okay. Pause point number 4 is the initiation of medication protocols. And as Lolly said, we need to do this. This is one of the things that we need to do rapidly, right, in order to minimize patient morbidity and mortality. Is that correct, Lolly? Yes. Okay. So we need to initiate magnesium sulfate loading dose and initiate an antihypertensive, all right, as quickly as possible. And then the last pause point is the post-event care and documentation. We need to form a synchronized timeline by the entire team, with the entire team's input. Medications given and times, seizure activity, characteristics and timing, the physician notification time, and arrival time at the bedside. This is not only medically important, but it's medically legally very important. And so we need to document that and have the team synchronized, make sure that we have the team saying, yes, this is the time that it was done. And then followed up by post-event care to include a delivery plan. ACOG is very big on that. Lolly, any comments about that?
Well, I think we're just experiencing a push about family involvement and family advisories. So this really helps with the participation of the family, debriefing them.
And then debriefing the OB team is the last one. Thank you. So just as a brief summary, in terms of our pause points, patient assessment, calling for help, recognition and initial management of seizure activity, initiation of antihypertension and seizure prevention medication, and synchronized timeline and patient post-event care to include formulation of delivery plan and update debrief of the patient and family. We'll finish with some basic ground rules for simulation that we need to adhere to, and if we cannot adhere to these, we can't go forward, okay? So let me go over them with you, and if you guys have any objections at all, we'll stop the drill and we'll talk about it, okay? All right, number 1 is with any kind of sim is maintaining confidentiality. Just like, the whole thing about Vegas, what happens in Vegas stays in Vegas, the same thing in sim. What happens in the sim drill stays in the sim drill. Are we all okay with that? Yes? Perfect. And then also corrections are not personal attacks. We're here to be your coaches, to make things better, to help patients. So this is what this is all about. Are we okay with that? Yes? Yes? Participate fully and suspend your disbelief. Just like in life, work as a team and support each other. Seems to help a lot in living life. Say aloud everything you are thinking and doing. That is very, very good for communication. Like the patient is seizuring, that patient has just experienced a seizure. It's good to know. People may have not been looking at the patient, all right? Do the action, do not pretend the intervention, especially when you're starting IVs. Ms. Allison's gonna talk to you about that, okay? The goal is learning. Mistakes are definitely acceptable in here in our simulations. Maintain professional behavior and attire. Giggling and joking are never, ever acceptable during a real resuscitation or a simulated resuscitation. And the drill master never tricks the learners. I am the drill master, and this is not what I do. I'm not here to trick you guys. This is all about learning. And so, any questions at all? No? All right. And now we're going to have Allison talk to you about standardized patient actor.
I'm going to step out of the simulation for a second just to talk to you about what a standardized patient actor is and kind of what we've grown to learn from using a standardized patient actor. And I'll let you know you'll know when we're stepping back into the simulation. I have no conflicts of interest or financial support. So what is a standardized patient actor? It's someone that is able to interact with drill participants with the participants during the simulation and patient encounter. And those encounters are designed to allow the participants to really feel their feelings and experience with a real person right there in the bed with them. And what's important with the SPA is that they are accurate and consistent and showing the behaviors and emotions of the patient and the disease symptoms. Using SPAs has been around for a long time. All the way back in 1963, they were using them to help in examination findings in paraplegic patients. And then in the 80s is when we really started seeing them in medical schools, nursing schools, and things like that. They're even used for examinations for medical schools and different healthcare professionals. And here in 2018, we started using a standardized patient actor, myself, in our RCDP simulation. So what we've drawn and learned from using the SPA is that it's an effective tool just because it brings the human factor into the simulation, and really it elicits emotions in the participants that they would encounter in a real scenario, and allows them to kind of work through that in the really stressful situation. It's also authoritative, being that I am also a labor and delivery nurse and do maternal transport. I have some experience in these types of scenarios and am able to provide feedback for the participants. It's also standardized, which helps all the different defined pause points. I am able to work off of those pause points as a coach and provide that feedback to the participants. And it's safe. It's a place for them to practice when it's not on a real patient, and learn in a really safe learning environment. So during the day, my day job is flying around all over South Central Texas to these different places we serve, and then you'll see a couple pictures there. The middle one is when we did shoulder dystocia, and then the last one's just me happy in the bed there. We're going to move back into the simulation of the simulation. Okay. I'm going to go over all the equipment that we'll be using. I'm Allison. I'll be Miss Monroe, I think it was. I am going to be your patient actor, and I will also be coaching you, though. So don't be surprised if I'm laying in the bed and say, pause, because if I notice that something hasn't been done that was part of our pause points, I'll stop you. The other important thing to know is that if I feel that something's happening in the drill that isn't safe for me or that we don't want you to do, we'll pause. So we want you to go through the drill just like you would, do all the things you would do. Do not pretend. The moment you start pretending, you lose that sense of disbelief. So we really need you to stay in character, do all the things, interact with me just like you would, and if we need to, we'll pause you and we'll redirect, okay? It's important that you wear your gloves just as you would. Again, don't pretend, and remember that I am going to be experiencing all the emotions. I'm probably very scared. This might be one of the most scariest moments of my life. And so I need that feedback from you and that support. Up here at the head of the bed, you'll see all of our resuscitative equipment for all of you. So there's a fetal monitor, which you can turn on, and you will hear fetal heart tones throughout the drill. We can give you a little example of that here in just a second, as it'll turn on here in just a second. You'll hear fetal heart tones just as you would, and you will hear these change, okay? We like to use a real fetal monitor because it really induces those labor and delivery emotions that we all have, right? Nobody likes to hear that. So this will be your vital signs monitor. When you place the blood pressure cuff on, just say, tap the screen to indicate that you want it to take a blood pressure, and you will hear the sound of a blood pressure, and you will eventually get your result. Here it comes. Once you have placed a pulse ox on, that's when you will see it. If you don't put the equipment on me, you're not going to get the information that you would get from it, okay? There's belts for you to use up here. There is suction in case if you need it. It'll be simulated suction, but the equipment's here. There's O2. You'll simulate turning it on, but you go ahead and put this on my face. Gloves are here. There is IV pumps ready to go when you get your medications that we've gone over in the hall. All your simulated medications that are brought into the simulation need to be put on the pump, drawn up if it's the labetalol or hydralazine. There is an ambu bag. We won't get to that, but we want to remember and stress the importance of resuscitative equipment at the bedside. Here are the fetal monitoring parts for you to put on. Nurse 2 will bring in IV start stuff. The only thing you won't do is actually poke me, but I want you to use the tourniquet, alcohol, and go through all the motions. And the important thing about that is that you feel how long everything takes, because that's really how long it takes, right? If we just say, oh, I put the IV in, no, you're not going to get out of this what we're hoping for you to get out of this. So did we miss anything? Does anybody have any questions? We good to go? Okay.
Okay. So Allison's going to go change into her standard patient actor thing. And then, showtime. Oh, do you have any questions about how we do the equipment and all that stuff? Fetal monitor. The fake heartbeat monitor, we don't call it that, Dr. Ramsey. We call it, it's called a fluke, and Dr. Gonzalez told me about it. We bought one. Unfortunately, it's only compatible with this really old monitor. You can see that's like from...
They're going to bring out the new version.
They're supposed to come out?
They're working on it. It costs about $3,000 to $4,000. And it only works, like Lolly said, on the older version fetal heart rate monitors, but they're working on getting it up to date.
Yeah, and it's called a fluke.
It's made by Fluke. It's made by Fluke Company, and
yeah,
that's why it's called a Fluke.
Oh, that's I thought it was just a fluke. I don't know.
So, but you can do a low fidelity version of that by just thumping on a. My wife is really good at it. She's an OB-GYN. Yes. So you could just have somebody sit and do that too, but that's really cool. Not working.
All right, and we forgot our urine cup. Damn. Okay. Other questions? Oh yeah, we need a urine cup. Does anybody have a urine cup up there? There you go. Do you have any tea-colored urine? Oh, there you go. I'm going to put a little soda. Xandra.
You know I don't like to share my soda.
So this is just to simulate. We all know how worrisome tea-colored urine is, right? Not only tea-colored, but Diet Coke colored. So this is her urine sample that's at the bedside. Where's Dr. Gonzalez's start? He's our director, and we do record all of our simulations, but we let the participants know. People are always really nervous about being recorded. They sign consents form. We reassure them that it's just, we do data collection on the times it takes to do everything because we want metrics, right, to see what we're doing. For the hemorrhage, we measured how long it took to go to the blood bank to get the blood. So literally in hospitals, after they did the order for the blood, the time that it took, and did those times decrease? So, and there are other metrics that we look at, and that's the only reason that we do the recordings.
So is it too dark for the audience? Is this too dark, or should we?
Oh, she.
And can you see the screen?
Maybe turn that little up. Oh, yeah, that's good. Is that okay?
How's that look, folks? Did it look better without the light or with the light?
It's good, Rob, where's that? Good.
Everybody's happy. You know how directors are. It's got to all be the set, quiet on the set, quiet on the set. Lights okay? Okay.
Okay, are we ready? Yeah? Okay, all right.
Your little director board.
Oh, that's right. The director, Dr. Ramsey, gave me this.
And the clapper. Here, I'll do the.
Hello, hello. All right. Okay, so this is University Hospital eclampsia drill number 1, correct?
Correct.
Okay. This is cycle 1. We're not going all the way through on cycle 1. We're going to start doing RCDP as we usually do, right? Correct? Actor, are you ready? Participants, are you ready?
Yes.
All right. Do we have audio? Actor, will you say something, please? Actor.
Ready. Testing.
Video on. All right. Action.
Hi, Ms. Brown. My name's Katie. I'm going to be your nurse today. What brings you in?
I have a really bad headache.
You have a really bad headache. I apologize for this bed being so low. Have you taken any medicine for it?
I took Tylenol, but nothing's helping.
When did it last start?
It started last night.
Last night?
Yeah, and it's really bad.
And the medicine didn't work?
No,
On a scale of 1 to 10, what would you rate it?
it's like an 8.
An 8?
Yeah.
All right. Have you had any changes in vision at all throughout your pregnancy?
Flashing light things.
All right. Well, let's take a blood pressure and see where you're at.
Okay.
All right. Starting electronic blood pressure. Just try and relax. All right, so your blood pressure is a little high. I'm
That's
gonna
a lot high.
I'm gonna call for another nurse and see if we can get some more supplies in. Can I have another nurse at bedside, please, with an IV start kit and some lab draws?
I'll be right in, Kate.
All right, Miss Brown, before you lay down, I'm just gonna check your reflexes, all right? Try and relax your leg. Wow, all right, so you do have some hyperactive reflexes. Let's get you laid down in the bed, all right? Have you had any, abdominal pain throughout your pregnancy? It hurts up here. Any facial swelling or notice any swelling in your hands?
I couldn't wear my rings the last couple of days.
No? Okay.
It's so bright.
All right. Actually, I'm just gonna check one more form of your reflex. If you could just relax your leg, okay? All right. So, hi, Marina.
Hey, how are you? Hi.
Hi, this is Miss Brown. She came in with a headache and changes in blurred vision. She is having some upper gastric pain in her right upper quadrant. She has clonus plus 3 beats, hyperactive reflexes, and an unrelieved headache. All right. Can you put the monitors on while I get the blood pressure cuff going? All right. Electronic blood pressure cuff started.
I'm gonna pause you.
Okay, so you're retaking electronic pressure?
Yeah. And what is our goal when we see a severe range pressure? When we see a severe range pressure, how do we validate that pressure? What's the goal?
By
with a manual blood pressure. So you're doing great. But at this point, as soon as you see that severe, maybe as you're calling your second nurse in, ask her to bring the manual cuff as well as all those other things.
And please remember to wear gloves as well. There's a box right there.
Okay, yes.
Okay. Thank you. Okay, we're just going to be all set up.
All right, are we ready? Actor, ready? Participants?
Yes, ready? Yes.
Okay, University Hospital, eclampsia drill, cycle number 2. Sir, we have video, it's on, audio on. Actor, please.
Testing.
Okay, got it. Okay, so action.
Hi, Miss Brown. My name's Katie. I'm going to be your nurse today. What brings you in?
I have a really bad headache.
A headache? When did it start?
Last night,
Have you taken any medicine for it?
I've taken Tylenol, but it's helped.
On a scale of 1 to 10, what would you rate it?
It's honestly like an 8.
An 8. Any vision changes that you've
I
noticed?
see like flashy.
Flashy lights? Okay. Let's take an electronic blood pressure cuff. Electronic started. Just try and relax, Allison. So your blood pressure is a little high. It's 196 over 121. Let me call another nurse. Is that high for you? Yeah? Okay. Can I get another nurse in here with an IV start kit, some lab draws, and a manual pressure, please?
I'll be ready, Kate.
Thank you. Before you lay down, let me just check your reflexes, all right? Try and relax. All right, so you do have some hyperactive reflexes, all right? Let's lay down in the bed. Okay. I'm going to check your reflexes one more time. If you could just relax your leg, okay? Alright, so you do have what we call clonus, okay? Any abdominal tenderness? Right there, in your upper right quadrant. Have you noticed any facial swelling or in your hands lately?
I can't wear my rings the last 3 days.
The last 3 days? Okay. Thank you. So this is Miss Brown. She came in with a headache. She has unrelieved by Tylenol. She does have swelling in her face and hands, abdominal tenderness. She has hyperactive reflexes and clonus +3 beats on either side. All right, I'm going to take a manual blood pressure, all right?
I'll help put some monitors on.
Thank you. And if you could get that IV started and some labs drawn, that would be great. All right, Allison, just try and relax again. So she does have a blood pressure of 220 over 110. Allison, that is really high. We're going to continue to monitor it, all right? And we'll continue to monitor baby. We'll get those labs sent off, and we'll evaluate when they come back. Okay?
Allison, I'm going to try to get your IV started, okay? I'm so sorry. Lights are bright for you?
We'll try and dim those as well.
Okay, we're going to go ahead and pause again this time. Now, we're going to go ahead and get everything started. Oh, okay. All right. So we've got the IV started. We did the manual blood pressure cuff this time. Was there any report to the doctor for orders?
No.
Okay. So just kind of back, we are working on timely report and so we can get things going.
Yes.
So as soon as you see that you validate your severe range pressure with a manual, you should be immediately probably getting on the phone with the doctor while Marina works on getting your lines.
Okay, we're going to rewind. I'll help with this.
Participants?
We're ready.
We have audio. We have video. Okay, University Hospital at Times to drill. Cycle 3. Action.
Hi, Miss Brown. My name's Katie. I'm going to be your nurse today. Can you tell me what's going on?
I have a really bad headache.
When did it start?
Started like last night.
Have you taken any medicine for it?
Tylenol.
Tylenol? It hasn't helped at all? Have you had blood pressure issues throughout your pregnancy?
No, never.
No? Any changes in vision?
I see like flashing lights.
Flashing lights? All right. Let's take a blood pressure
Okay.
and we'll see, we'll go from there. Electronic blood pressure started. So it is elevated. Let me call for a nurse. They're gonna bring in some supplies. Can I get another nurse in here with with a manual blood pressure cuff, IV start kit, and some lab draws, please?
Yes, I'll be right in, Katie.
Allison, before I lay you down, let me check your reflexes, okay? So you do have some hyperactive reflexes. Can we lay you down? All right. Before you get under the covers, let me just check one more thing. So you do have what we call clonus on either side. Have you felt any abdominal tenderness?
Right here.
Up here in the right side? All right. Any swelling in your face or your hands recently?
I feel like I haven't been able to wear my rings for like 3 days.
Okay. And you've noticed some changes in your vision?
Mm-hmm.
Okay.
Hey, Katie, how can I help?
Hi, this is Miss Brown. She came in presenting with a severe headache that's been unrelieved by some medication. She has clonus beats +3, hyperactive reflexes, abdominal tenderness in her right upper quadrant, and she has noticed swelling in her hands and her face. If I take the manual, do you think that you could get her onto the monitor for me?
I'll help put monitors on. Allison, my name is Moreno. I'm gonna help get some an IV started on them. Okay. Baby moving okay? Yeah. Baby's okay.
Okay, Allison, if you could just relax. Okay, so you do have 220 over 110 blood pressures. I'm gonna call the doctor if you could get that IV started and those labs drawn. Hi, Dr. Ramsey.
Hey, Ms. Maddox. What's going on?
I'm with your patient, Ms. Brown, in LDR 12. She came in presenting with a headache, unrelieved by Tylenol. She has some swelling in her face and her hands, some upper gastric pain on her right side. She has burst reflexes, clonus +3 beats on either side, and we took a manual that was 220 over 110.
So our manual was 220 over to 110. Why don't we start some labetalol, 20 milligrams IV push. And I do this is this AIM thing, so we want to get magnesium after we give the labetalol. So start that, and I'll be on my way over.
Okay, so just labetalol,
And then
20 milligram push, no magnesium?
and start the magnesium now too.
And the magnesium?
Yeah, but start the labetalol first.
Okay, and to clarify, that's going to be the 4 grams
That's correct.
All right, when can I expect you?
I'm on my way right now.
Perfect, I'll see you in a little bit. So that was Dr. Ramsey. He wants us to start a 20 milligram labetalol IV push, as well as the 4 gram bolus of magnesium, and then a 2 gram per hour magnesium run after that. All right.
Allison, your IV's in.
Oh, she's seizing. Can I get a third nurse in here?
Why is she
She's
seizing?
seizing. It's
What's
because of her high blood pressure.
I'm here, Katie. What's happening?
This is Allison. She started seizing about 5 seconds ago.
What do you need me to do?
If you could help me stabilize her, we're gonna put the side rails up. Marina, if you could go grab the meds for us, the labetalol and the magnesium, we're gonna get, Marisol, she'll help me.
Is that
Hold on.
or is that the heart?
Okay, so great job getting into a safe sideline position and getting the, I heard you I'm sorry, I keep forgetting this. I heard you simulating putting up the side rails. Unfortunately, we don't have them today. And good report to the physician, yes. What is one thing we really want to be sure to do when somebody's having a seizure is support them with supplemental oxygen. That's one thing we can do to help mom and help baby, because you will expect for those her O2 sats to drop, and so just be sure as soon as possible to get oxygen on. So let's start from the top.
And a pulse ox as well.
And a continuous pulse ox. Thank you, Lily. All right.
Okay, let me help him. Yeah. And one thing you can see is we're all coaches here. Let me get that off. Yeah, we're gonna do 4, where they don't get a little bit. No, we're gonna do all 5. No, we're gonna keep it. It's only 4:30.
Thick 4, yeah.
Yeah, it's in this mess. Don't get the pulse ox. What are you looking for? What are you looking for? Oh, it's right. Okay, I'll find it. No, I had it just a second ago. Here it is.
Oh, okay.
All right.
Yeah, so there was a question of when I give an order they asked me for orders for labetalol or activating the hypertensive order. I usually will specify the medication. I prefer myself hydralazine, so I'd go to that first. So I'll specify the initial medication and then activate the protocol for that going forward. So it depends how your system's set up for it, but we all have the guidelines in place now, so we can autopilot that pretty much. Good question. Anybody else have any other questions while we're resetting? Great.
All right, ready?
Actor, are you ready? Yes? Yes. Participants?
Ready. Ready.
Okay, this University Hospital, eclampsia drill number 1, cycle number 4. Actor, give me a sound check.
Sound check.
Okay, video is on. All right, action.
Hi, Ms. Brown. My name's Katie. I'm going to be your nurse today. What brings you in? When did it start? Last night. Did you take any medicine for it? Tylenol? And it didn't help?
No.
No? Have you had blood pressure issues throughout your pregnancy?
No.
No? Any vision changes?
I see like flashy.
All right. We'll just try and relax. We're going to take a electronic blood pressure. Electronic blood pressure started. So your blood pressure is elevated, 194/121. Let me call another nurse in here, and we'll get some supplies. Can have another nurse in LDR 12, please, for a manual blood pressure cuff, an IV start kit, and lab draws.
I'll be right in, Katie. Oh.
All right, let's, before you lay down, let me check your reflexes. Okay. So you do have brisk reflexes. Let's get you laid down. All right, before you get tucked in, let me just try to check one more thing. Relax. So you do have what we call clonus. Any abdominal tenderness that you've noticed? Up here on this side? Any swelling in your hands or your face lately?
I haven't been able to wear my earrings for the last 3 days.
No? Okay. Let's see. Hi, Marina.
Hey.
Thanks for bringing the blood pressure cuff. Can you get an IV start and some lab draws? This is Miss Brown. She came in presenting with a headache and changes in vision. She does have some abdominal tenderness in the right upper quadrant. Clonus beats +3, hyperactive reflexes.
Let me help you with monitors first.
Thank you. Baby still moving okay?
Yeah.
All right. Again, just try and relax.
You feeling the baby move okay? The white spot in here?
Yeah.
So sorry.
If you don't mind.
So she does have a blood pressure of 220/110. I'm going to call the doctor. Hi, Dr. Ramsey.
Hey, Ms. Maddox. How are you?
Good, how are you? I have your patient in LDR 12, Miss Moreno. She came in presenting with a headache, changes in vision. She does have some swelling in her hands and her face, right upper gastric pain, brisk reflexes, and clonus +3 beats on either side.
And what's her blood pressure manually?
Manually, it's 220/110.
So it sounds like she's pretty sick. She's got a headache, vision changes. Let's give her 20 of labetalol IV now, push, and you can activate the labetalol protocol. And let's start a 4-gram bolus of magnesium and start an infusion at 2 grams an hour. And I'll be right over.
All right, so just to clarify, 20 milligram IV push of labetalol, and then a 4-gram bolus of magnesium followed by 2 grams per hour.
That's correct.
Okay.
I'll,
Can I expect to see you?
I'll be there in about 5 minutes.
Okay, perfect. Thank you. So that was Dr. Ramsey. We're going to start a 20 milligram labetalol IV push, and then 4 grams of magnesium bolus followed by 2 grams per hour after that. All right.
Labetalol and mag, 20 milligrams of labetalol.
Yeah, baby does have minimal variability right now. Okay. We have those started.
Yes, got I drew labs.
She's seizing. Can I get a third nurse in LDR 12?
What's happening? Why is my
What
happened,
Katie? Starting the oxygen.
What's going on?
What's happening?
So this is Miss Brown. She's seizing. She does have elevated blood pressures. What do you need to do? Can you take over for Marina? Marina, can you go get the medication, labetalol?
Is she gonna be
We're
all right?
putting up
I'll
the
go
side
grab
rails.
meds, take the labs.
We do have suction at the bedside if needed.
Or is that the patient's
Let's
heart rate?
readjust. So this is baby. Baby's in the 90s. Let's turn her. Flip her to our other side. Allison, how are you doing? Can you hear us? How are you doing, Allison? Let's readjust the monitor. Allison, how are you doing? Can you hear us? Can you talk to us? The oxygen's going. Hi, Marina. Can you get the magnesium started since we did have a seizure first? We need the start fluids going. All right, let's flip her back to this side. Allison, we're going to rotate you, okay? Can you talk to me, Allison?
Why isn't she talking?
All right, hold on. She's not talking because she just came out of a seizure. Dr. Ramsey, your patient in 12, Miss Moreno, she has had a seizure.
Great.
Baby's heart rate is backed up.
I'm walking in the building right now, Ms. Maddox. I'll be there in just a second.
Perfect. Retaking electronic blood pressure right now.
So how's she doing now?
Yes. She just came out of a seizure. Started about a minute ago.
This is the baseline.
We have the main line started. We're going to get the magnesium going.
And she got her labetalol already?
She did not get her. Did
let's-
you give the labetalol?
Marina did. I drew it up, but I thought you were.
Let's pause.
Oh, no.
pause. So we learned today that it's really important to do your antihypertensives first because she's at risk for stroke. So that was important to start that. And there's communication issues in play. Sorry, I'm not used to doing the team thing.
I thought you were given it.
Oh, and that's
So having a good handoff among the team is important. So we want to make sure that happened first before the magnesium.
Reset.
This is going to be the clean run, right? This is the last one. We're going to do a clean run. Last one, clean run. Clean all the way through, right?
You got the blood pressure cuff? Yes, and you take.
Sorry, I didn't get you one hooked.
What?
They want to do the beginning of time.
No, I think it's getting kind of long. Look, these people are dying. I think we should just go to do a clean run.
Actually, we're going to do the time.
So we're going, when are we stopping? I know, but what is this? You guys figure it out. So who's pausing this one? Who's pausing it?
I think they're trying to figure that out.
Participants, you guys ready?
We ready?
Okay, actor, give me a sound check. Okay, video is on. University Hospital, eclampsia, drill number 1, pause, cycle 5. Correct? Ready? Action.
Hi, Miss Moreno. My name's Katie. I'm going to be your nurse for today. What brings you in? A headache. When did it start? Last night. Did you take any medicine for it? Tylenol? And it didn't help? Have you had any changes in vision throughout your pregnancy? Any blood pressure issues? No? Okay, I'm going to take an electronic pressure. Started. So your blood pressure is elevated, 182 over 118. I'm going to call for another nurse to bring me some supplies. Can I have another nurse in LDR 12 with a manual blood pressure cuff, an IV star kit, and some lab draws, please?
I'll be right in, Katie.
All right, before you lay down, Allison, I'm going to check your reflexes. So you do have brisk reflexes. Let's get you laid down in the bed. All right. And before you get under the covers, I'm just going to check one more thing. So you do have clonus, all right. Any abdominal tenderness? Up here on the right side. Have you noticed any facial swelling or swelling in your hands lately?
I haven't been able to wear my rings for like the last 3 days.
Your rings the last 3 days? Okay, Morena should be in just a sec with the blood pressure. Hi, Morena.
Hey.
This is Miss Moreno. She came in with a headache, unrelieved with Tylenol. She does have clonus plus 3 beats, hyperactive reflexes, abdominal tenderness in her right side, right upper quadrant. some swelling in her hands or in her face. Can you get baby on the monitor for me? Okay. All right. Just relax, Allison. I'm gonna take a manual blood pressure, all right? So your blood pressure is 220 over 110. I'm gonna call the doctor and report that. Moreno, if you could get the IV started and the labs drawn.
Hey, Ms. Maddox.
Hi, I have your patient, Ms. Moreno, in LDR 12.
Yeah, how's she doing?
She came in today with a severe headache, unrelieved by Tylenol. She has some swelling in her upper extremities as well as her face, right upper quadrant pain. She has brisk reflexes and clonus plus 3 beats on either side.
Do we have a electronic or a manual blood pressure yet?
Manual blood pressure is 220 over 110 at this time.
Her blood pressure is 220 over 110. She has a headache and right upper quadrant pain. Why don't we give her 20 milligrams of IV labetalol push now, and you can activate the labetalol protocol. And let's give her 4 grams of magnesium IV net load now and 2 grams an hour, and I'll be on my way over.
Okay, so just to clarify, 20 milligrams labetalol IV push, and then 4-gram bolus of magnesium followed by 2 grams per hour after that.
That's correct.
And how long until I can?
Probably about 5 minutes I'll be over there. I'm just finishing up in the office.
Okay, perfect. Thank you. Okay, so that was Dr. Ramsey. He would like a 20 milligram labetalol IV push, and then 4-gram bolus of magnesium followed by 2 grams hourly after that. All right. Allison, how you doing? The lights are bothering you? All right. Let her just finish up that. You can get those labs sent, and if you could grab those meds, that'd be awesome. All right. Oh, she's seizing. Can I get another nurse in here at the bedside, please?
Yes, Katie, what's happening?
Started.
You're okay.
So this
What's
is-
happening, Katie?
So she started seizing about 30 seconds ago. If you could be our timekeeper.
Okay, what else do you need me to do?
If you could take Morena's spot, can we put the side rails up? Morena, if you could go and get the magnesium as well as the labetalol started.
Is that mom's
This
pulse
is-
or the baby's heart rate?
This sounds like baby. Been down for 10 seconds. Let's
10
flip her over to
seconds.
the other side. All right, baby has minimal variability right now. All right, Allison, how are you doing? Can you hear us? How are you doing, Allison? All right, baby's down still in the 60s. Morena, can you get that mainline started, please?
Yes, this is right away.
Allison, how you doing? All right, let's flip her back to the other side. Allison, can you hear us? All right, mainline is starting. We're gonna do the 20 milligrams labetalol right now.
Yes, I'll draw it up.
Perfect. How you doing, Allison? All right. Sounds like baby's coming up. Allison, can you hear me? You doing all right? All right, labetalol started. Now that the seizure's over, I'm gonna take another
20 milligrams.
electronic blood
Starting with
pressure.
that.
All right, electronic blood pressure started. Allison, how you doing? Can you hear us? Is that the magnesium?
This is the magnesium sulfate. I'm
So
starting
we
the
have the
4-gram load
20
now.
Hey, Ms. Maddox, I'm here now. How's she doing?
Hi, Dr. Ramsey. So she just had a seizure. Can you give the timeline, Marisol?
When did you call me, and when did she get her labetalol, and how long has it been since the dosing?
She just got her labetalol. She started seizing about it was about 15 minutes ago.
How long did she get the labetalol?
It wasn't.
You just gave it?
Was somebody keeping track of the timeline?
We just had that right now.
I don't think so.
Okay, so pause.
Okay, so it's really critical that somebody gets assigned to be the timekeeper in this kind of situation so that you know when the seizure started, how long the seizure lasts, when medications were administered, and when the doctor arrives at the bedside. So maybe when Katie, when you have extra help in the room, decide somebody, because it's going to be difficult for you to be the timekeeper probably in this situation. Maybe Marisol, as you come in, you can start being the timekeeper. Okay?
Okay, so those are our 5 pass points. And we went through each one trying to illustrate. In the rural communities, when we do simulation, we enacted this and we purposely put in mistakes there. Just want to reassure you that these nurses, they were very concerned about that. But then we're going to do Dr. Gonzalez is going to do a debriefing, and then we have a little bit of time for questions about how we conduct the drills. Okay.
Okay, so basically we're going to do an after-action review. If we could get all the participants. Just a quick after-action review. So what were your thoughts about the methodology, the method, the rapid cycle deliberate practice? What did you all think about that?
It was really scary. I was really nervous. I was actually shaking during the simulation. I felt like it helped that y'all reviewed it ahead of time. So I knew what needed to happen, but it was all going through my head really fast during the simulation.
So you appreciated the fact that we reviewed everything before the sim and that you were quite anxious about it. Is that right? Okay. What did you think about the rapid cycle deliberate practice method of doing the sim?
I think it helps with establishing the roles because as I came in, then towards the very last of it, it was kind of hard for me to understand like what exactly I needed to do there and what was my role. Seeing that already, the nurses were already doing the things that I thought that I would do. So establishing those roles, and then it kind of alleviates some of that burden of having to figure it out for myself.
So what I'm hearing from you is that you liked the fact that we had assigned roles for you and that you knew what the role was going to be beforehand. Yes. Okay. What did you think about the whole RCDP method?
So I am not a great actor, and I thought that it helps you play that role, and it gives you the experience that I think a lot of young nurses need. So stepping out of the simulation, I've only been a nurse for a little while. And we did this, I got kind of pulled into this randomly, and we did it with shoulder dystocia. And I'd never experienced this shoulder dystocia in real life. But right after we had done it, we experienced one on the floor, and it was like I knew exactly what to do, what needed to be done. And which, if I hadn't have done this or taken part in this at all, I would have never, like, I knew what a shoulder dystocia was, I knew how to do it, but in terms of actually physically doing it myself, I realized like how lost I would have been. So it kind of opened my eyes that like it's a good experience for young nurses, as well as people who don't experience these situations on a daily basis at all. It really does help solidify what's going on, who needs to do what, the importance of roles in a room, especially during an emergency situation, and how chaotic it can get, and everyone kind of lose the direction of what needs to be done with everyone trying to do different things at once. So I found this experience to be like eye-opening as well as really valuable to the floor that I work on and everything. So going back into the sim, I mean, I just get nervous when I'm doing something for the first time, and I haven't experienced a seizure. So this is something that I think is very valuable to me in terms of I could take it back and actually put it into play at work.
So you, right. So you thought that this was a good experience for you. Let me dig deeper than that. Why did you think it was good? What were the facets of the rapid cycle that you felt really got to you in terms of making this a positive experience? What were they? I mean, repetition, the coaching.
I'd only done simulation, and like in school, you work on simulation with starting IVs and like how to do a head-to-toe assessment. You're not interacting with a real patient and them asking random questions that you have to then come up with an answer with because you don't know what she's necessarily going to ask you. So it does kind of keep you on your toes. And then the repetition. I know I'm not perfect, and I don't think anyone is, but when you are forced to redo it over and over again, it kind of gives yourself that plan of action that even if you don't follow it directly in a room, you kind of know what direction to go to.
Right. Thank you. Yes.
I appreciated that they stopped us so we don't hardwire mistakes. The pauses, right as you're making the mistake, pause and correct it right then and there. Because the last thing you want to do is let that go by and then you're hardwiring it in our brains.
Right. Dr. Ramsey, what did you think was interesting about this?
Well, I think it's the repetition and the stop, and you go back and reset the whole thing and go again. It takes time, but I think that repetition, doing it the right way rather than, like you said, doing it and then making a mistake and just keep going, you may not realize that. We'll talk more in a second about the family member, which is a huge asset to a sim, but let's finish up this part, and I just want to make a couple comments on that.
What do you think that we could have done better in providing you with a potentially better experience? How could we have done this a little bit differently so that your experience would have been better? And please be as honest as you can be.
The cameras made me really nervous. I think that added more to my anxiety about my performance.
I think too, doing it outside of the setting, like the real hospital room, so maybe a little closer to the scene of the feel and the look of a hospital room. Yes. Hmm?
What could we have done a little bit better to make this a better experience for you?
I think it went great. I just needed a larger pair of gloves towards the end. My hands were sweating a lot. But other than that, I thought we did really well.
I'm so sorry.
It's okay. I think it's important. I don't think we talked about this a lot in the beginning, and about how tiring this is. Running this drill and being under this level of stress over and over for several cycles is really hard work, and you guys really powered through it. And I know you're exhausted, but I think you really probably do feel like you have some muscle memory, right? After doing that so many times.
Yeah, I hope you guys do too.
Dr. Gonzalez, can you comment why you film it?
So the reason that we videotape it is not so much to go over the videotape with the participant, but for us to subsequently go over and do a cold debriefing with the coaches and to see what our behavior has been and our actions have been. Believe me, the way we coach today is incredibly different from the way that we coached our very first shoulder dystocia drill back in 2018. It's changed dramatically. Lolly, do you have a comment about that?
Yes. The short answer is yes.
And can you elaborate?
We weren't nearly as prepared, and I wasn't prepared in all the research about shoulder dystocia. Luckily we got to use the ACOG guidelines, but it was not a well-oiled machine at that point.
I think we had to learn how to not feel bad for correcting people, and Lolly's so sweet and would always want to say, I'm sorry. And as coaches, we had to really learn to just, it's very objective feedback, directed feedback, and everyone gets into that culture as you set up the drill so that the participants don't feel bad when you do correct them. And that was hard for us to learn, at least for me and Lolly. Dr. Gonzalez is better at it.
Just one more thing, with the timekeeper, a checklist that's easy to pull out and to keep track of time and the actions, that too, very helpful.
And I'll just make the comment about having a family member simulated into this is so powerful. I did the Society of Maternal Fetal Medicine has a critical care simulation course, and they brought in a very agitated family member into the simulation during an eclamptic seizure, and we didn't do a good job of that. Nick got pushed away fairly quickly, didn't give him good explanations, but that's a hard thing to balance when you're in an obstetric emergency, but they need to be brought into it, and that throws a huge element into the equation that's unpredictable. So if you have that person be random on how they act is really important. And I think Marisol made another good point, is doing this in situ in your unit, where they actually have to run and get the meds from where the Pyxis or wherever they are. We've learned a lot about hemorrhage sims by just like, well, didn't know that, don't know, or going to the blood bank to get blood, you need to know the physician's name. Nobody had the name, so we had to figure that out and have a process to fix that. So doing it in situ is really helpful. And definitely encourage a patient, family members incorporated into the sim once you get it working. Super powerful. And for Mommy's Voices for bringing that kind of thing up.
So just 2 more questions and we'll be done. Oh, what was your experience? What was your opinion about the use of a standardized patient actor in a simulation?
No, I think she did a really great job, but I appreciated that it made it really, it was a human experience. As you know, we've done a lot of simulations with even the high fidelity mannequins that can groan and moan and bleed and all that stuff, and that's all great in a different setting. But for me, I was able to interact with her and look into her eyes, and it just makes it more human and added that emotional component to the care we deliver.
Your experience, what was your reaction to dealing with a standardized patient actor?
It brought up in me more of that sense of urgency than with the like the simulation dolls. So that's my benefit of that I felt it, the sense of like act now.
Yeah, I thought the sense of urgency, it really brings that to light. Along with this thing, I never realized how much this affected me until we started doing the simulation, and baby's heart rate was going down. So you're trying to listen to that as well as manage a patient. And also you don't know what she's going to ask or what she's going to say. So you kind of have to know where to come at it, kind of at all different angles.
The last question that we ask out on the road when we're doing these sims is, what is the one thing you're taking home today, if anything at all?
Validate your blood pressures quickly and call the provider right away.
One thing you're taking home today, if anything?
A checklist. I'm still with a checklist.
Closed loop communication, I think, is really valuable when it's more than one person who's managing and hanging medications and seeing what meds have been hung and the orders have been done correctly.
Well, thank you very much. Do you all have any questions about the methodology or the actual drill?
I'm just curious that you had the same primary nurse throughout the whole thing, so I think it'd be really great for Katie to be an expert at this, but do you find that the others learn as well when they're not in that role?
The short answer, forgive me for grabbing it like that, forgive me. The short answer is yes, that they get a lot out of it. We've asked that very same question to other people. And we actually, when we have time, we actually rotate the leadership position, but it depends on time, as you can well see. But again, the short answer to whether other people's that are non-leaders, whether they get anything out of the drill, the answer is yes, that they seem to get a lot, because we've asked that question specifically to the participants, and they all stayed in the affirmative. And the other thing, our first year experience with shoulder dystocia, we got 3 take-home messages. Number 1 was the fact that they loved rapid cycle deliberate practice. That was our take-home message from visiting a bunch of South Central Texas rural hospitals. They absolutely loved the experience. They loved the try again, to repeat, to get, and even to get corrected. The second thing that we learned was the fact that they loved the interaction with the standardized patient actor. They absolutely were engaged by it, and they seemed like it's incredibly realistic. And the third thing that we learned in terms of the shoulder dystocia experience that we had in 2018 was the use of a timekeeper. That telling time in a code situation is the most difficult thing humans can do. When we're under stress, for us to take time, that it's incredibly difficult, and especially when rooms don't have user-friendly clocks. And that's the majority, unfortunately, of our L&D rooms in Texas, it seems like, at least in South Central Texas. So those were the three major take-home messages that we got. But we actually asked that question that you just asked about non-leadership in the room. But anyway, Dr. Ramsey, I'm sorry.
I just had a quick question from a provider standpoint. I can almost 100% guarantee that we do not validate the blood pressure with a manual cuff. I don't even know if we have manual cuffs on labor and delivery, and I don't know the last time our L&D nurses actually took a manual blood pressure. I'm sorry. So I was wondering, I was trying to do a quick Google search so far as evidence-based on automated versus manual. And most of the literature seems as if it supports that the automated seems to be very reliable. So is this an ACOG recommendation? Is this a simulator? Okay.
And actually, I had to Google it because Dr. Gonzalez, because Allison, in their practice, they have to verify with a manual cuff. And I kind of was wondering the same thing. And Dr. Gonzalez always makes me verify everything. So in that bulletin, it does say that that's the gold standard. And then the subsequent blood pressures you can use electronic once you've established.
The only time we use manual is when we have palpatory. That's the time we run with our manual.
Right.
We have our manual in the unit, but we don't really use it.
It's probably more available than the fetoscope, though, right?
We're going to have to wrap it up. We're going to. Okay.
Yeah, last question.
Last question.
And we'd be happy to stay because we, of course, love what we do.
And we don't want to get in traffic on the way home.
Okay, we have a last question.
I'm just curious, in your institution, how do you manage facilitating the drills for real-life scenarios in your own hospital?
I want to actually advocate more for this because our facility doesn't really do it, which I never did it until becoming a part of this team. And it was just like, oh, we're getting filmed on this commercial. Do you want to play a role? And do you want to take part in this thing that we call rapid active cycling simulation? And I was like, yeah, sure. Like I could learn something and take part in it. And after that, it was kind of like, wow, this is really eye-opening, and it really does work. Because like I said, like the next day we had a shoulder dystocia, and I knew exactly what to do and how to manage it. And we don't do it on our floor. So kind of like starting to talk to management about taking the time to do it, because it is really time-consuming. And it does take a lot of time away from, like, you'd have to have several nurses off the floor in order to do it. But trying to fit it in, personally, like, I think it would be very valuable to a unit, and I think it's something that we should take into our practice. Because we help so many surrounding hospitals. I think that, like, our own nurses would actually value from it as well.
Yeah, and I can add to that after Maria. Go ahead. Oh, you go first.
Well, I work in a rural hospital, and simulations is how we keep trained, right? Because the chances of us having those situations is less when you deliver like 40 babies a month. So you have to, and our staff, Dr. Gonzalez, started a simulation program at our hospital a couple of years ago with a rapid cycle deliberate practice, yeah. And we were so impressed by the RCDP and how it worked in neonatal. We have not, to tell you the truth, we do rely on the level 3s and 4s to come out and do simulations with us, but there's been so much enthusiasm and eagerness by our nursing staff to really do more. They really want to do more because they don't want to get caught in that situation where we weren't prepared. We have just recently established an education committee, and it's a simulation committee, and the nurses that are on it, we have 2 on day shift and 2 on night shift. It's not a big, huge staff. 2 on day shift and 2 on night shift, they get together and they plan the simulations, and then they do it. We have low census nights. or low census days when I literally have 3 nurses waiting for somebody to come through because we don't have anybody in labor that day or whatever. So those are the opportunities we take to, pull out the simulation kit and let's do it. Even if it's just a simulation of, we had a massive transfusion a few months ago where putting the order in the computer was, we didn't know how to do it. Like, you get nervous and, how do you do it? And so show me how you put in an order into Meditech to order the master transfusion. I mean, it's that simple, but the nurses were like, oh, they're so glad now they know how to do that. But you have to cycle it. Everyone's, show me how to fill up a Valkyrie. Show me how to use the blood warmer, and then the simulations. But the team approach is, I'm hoping we can rely on.
Marisol, you want to make a quick comment, and then we got to close it up?
Yeah, one last.
Yes, I wanted to add to what Katie shared. So we have been doing standard simulation in our hospital since 2018, being led by Dr. Sarah Page Ramsey. But those are like interdisciplinary standard simulations where we try to get as many as providers and anesthesiologists and so forth, and then the nursing staff. But we were faced with many challenges that the patient activity would come into play, where I think we had to cancel 1 or 2 because it didn't lead to doing it. And then the other challenge is that we were making it voluntarily open for staff nurses to come in and participate, and they didn't want to come on their day off. And so after assessing how successful that was, for our nursing staff, we were only hitting 10% of our nurses. So this year, what we are doing, and I needed support from management, that if we needed this to happen, then to allow them to come in, to get paid for coming in. And so then this year, we're trying to build a curriculum around this method, this methodology, not in the situation, but in our simulation lab away from the floor, because the other thing that we found out is that it builds a lot of anxiety on the nurses that are already on the floor taking care of patients and then having to participate. They, of course, goes without saying, they want to be with their patients. And so, but it built a lot of anxiety. And so bringing them off the floor into another setting like the simulation lab and on their day off, but getting paid for it, it has shown so far in the last 2 months that it increases their interest and they feel safer. So we're trying that now, but we needed management support to allow us to do that with them.
Thank you. Thank you, Marisol. And thank you very much. Our time is way over. So
let's give my round of applause.
Thank you. Thank you.
Just quickly, I just want to thank the university folks, but also secondarily, if anybody parked and got one of these blue tickets, I do have validations for those. If it's not in a garage with one of these, unfortunately, I don't. But I'd just like to thank the university staff for coming and doing this.